All right, defining, measuring, and valuing costs. So remember, our goal with CEA is to calculate an ICER, an incremental cost effectiveness ratio. That's our outcome. And in order to do that, we need to understand cost and we need to understand effects. And so today we're going to be talking about cost. Now, if I asked you to think about cost, the first thing that probably pops into your head is a dollar sign or, how much something costs. But when we do CEA, I actually think it's more important to think about it as the number of a resource that gets used. And so we want to start with what resources are important to our question, how much of that resource is being used, and then think about how much that resource actually costs. What's a dollar value that makes sense for that resource? Now, there's a couple of definitions that I want to throw out here that are not just related to cost, but they're going to come up over and over as we do CEA. And the first is something that is stochastic, and that is just a fancy way of saying randomness. So these are when we have a stochastic variable, we're not going to set the variable. We're going to allow some probability in. Yeah, so I mean, I maybe it just makes more sense to show you the example. So I have this example here of a patient having a myocardial infarction. They have a heart attack. They spend blank days in the hospital. So this variable is going to vary by patient to patient. And when we put these variables into our model, we're going to also allow it to vary. And then we have deterministic, which is just a way to say without probability or without randomness. And so this is when we're going to specifically assign a number. And this is used, again, both for costs and then probabilities and other variables. So going back to our example, if we say, well, on average, a patient spends 4 days in the hospital, we can directly input that into our model and then use that number when it comes to costing. So the way that we do costing in CEA is first we identify the different categories or the different resources that are important to our question. So again, what is being consumed? And then we measure how much of that resource is being consumed. And then finally, we apply a dollar value to it. And I think this will make a little bit more sense as we go through it. So the first step again is identification. And identification is heavily relied on or influenced by the perspective that you take in your CEA. And so this table right here is called an impact inventory. This was published in an article in JAMA that is the guidelines, more or less, of standards that you should follow when doing CEA. So there's a couple things I want to point out here. First, let's talk about perspective. So the two most common perspectives are the healthcare sector perspective and a societal perspective. Now, there are other perspectives that you can take. These are the two that tend to get used over and over in most CEAs. And then what this is doing is showing you what costs or what resources you should be considering in your CEA given these two perspectives. So let's just talk about healthcare sector first, because this is the most straightforward and maybe the most common perspective used in CEA. So you see that with the healthcare sector perspective, they're only suggesting that you need to look at these costs right here. So something that is directly incurred by the healthcare system or sector. First we're going to kind of skip over health outcomes, and we'll just go right to medical costs. And so the costs that we care about are anything that's paid by third-party payers, so insurances, patients' out-of-pocket costs, future-related medical costs, and future unrelated medical costs. So again, anything that's paid for healthcare, direct healthcare costs paid by. We don't care who pays for it, I guess. If it's a direct healthcare cost, then we want to include it. Now, if we do a societal perspective, you can see they recommend a lot more, and a lot of these costs are very difficult to obtain. and hence societal perspectives are often not used. So now we're going to look at informal healthcare sector costs. So this includes patient time, unpaid caregiver time, and transportation costs. So a lot of these are patient-related costs. And then you have non-healthcare sector related costs, which are rather complicated to look at and to actually evaluate. I'm not going to go through this list. You can see it here. These are almost never included in CEA. Not that they're not important, but they're just rather difficult to think through and obtain. So there's a couple of different. So again, we're still in this idea of we're still identifying the resources that we're using. And we have two major approaches. One's called gross costing, and the other is called micro costing. So gross costing is what I almost always use, and this is when we take, we're trying to bundle resources together. So for example, if we go back to that myocardial infarction example, we can think about a patient having a myocardial infarction as, well, how much did the entire hospitalization cost? Or if we do a micro costing approach, we're going to try to identify all the individual resources that were consumed. So we're not going to just like lump sum say, well, a day in the hospital costs X $1,000. We're going to go through and say, there was the nurse time, there was the doctor time, these were the labs that were drawn. Excuse me. These were the medicines that were consumed. So there really are just kind of two fundamentally different approaches. What I typically care about with my analyses is what were the costs that incurred on average across a group of patients. And so I rarely actually need micro costing. Micro costing becomes important if the individual level resources are important for your analysis. And often for my analyses, they just aren't. And microcosting tends to be more complicated to do. We're not going to spend too much time on measurement. And the reason is that it is so context specific, meaning that every study that you do is likely to be a little bit different. And when I say measurement here, I'm talking about how we go about measuring how often the resources were consumed. So so for example, like, well, we'll just kind of run through these. So these are just a handful of ways that we can go about thinking about how often a given resource is used. So you can collect it alongside a clinical trial. You can obtain it from hospital records. You can go into patient case notes. You can ask the patients in surveys or interviews. You can just do expert opinion, which is often what I do. And when I say how often a resource is used, let's use warfarin as an example. So warfarin is a medication, an anticoagulant medication, and along with taking warfarin, patients measure their INR, which is a lab value that tells you how anticoagulated, or maybe in layman terms, how thin someone's blood is. And then we use that INR value to adjust the dose of the medication up and down. Now, how often patients actually get an INR drawn is variable. And it can vary both from institution to institution and from patient to patient. So a patient who has a very stable INR, meaning we kind of, their dose is more or less established, it's not varying very much. Every time they come in, it's within range. We're going to start to spread out how often we have their INR drawn. But someone who has a lot of INRs that fall out of range, we're going to start to have their INR checked more frequently. Now, when I build a model, I don't actually know how often I should. The question becomes, well, how many of those INR lab draws get consumed by patients on average? And so there's a lot of ways to come up with that number. I can look at EHR records, but a lot of times it's just as simple as asking our our anticoagulation specialists who actually treat these patients and say, well, in your opinion, how often do patients on average going to get INRs? And so that's called expert opinion. Expert opinion is not the ideal. Ideally, you actually want some objective numbers behind it, but it is a valid way to do things. And so that's what I mean when I say measurement. And there's a million different ways to measure how often resources are consumed. This is an example from the textbook that was used in a clinical trial where they actually just went through and asked patients these questions. They said, during the last month, how many times have you done these things? And then, so this would be an example of collecting this type of data alongside a clinical trial. And now we have to value those resources. So we're at that third step. So we've identified the resources that we think are important. We've identified how often those resources are consumed or how much of the resource is consumed. And now we have to provide a price value associated with those resources. And in theory, the price should be the opportunity cost. In reality, we just use market value. So what people are reasonably paying for that good or that service is just fine for our purposes for determining the dollar amount associated with the resource. Now I'm going to run through just really quickly a handful of common costs or resources and where you can potentially get costing data from. Now, there are so many more potential resources than what I'm going to show. It's kind of impossible for me to show both all the types of resources consumed and all the potential sources of costs for this data. A lot of this is just going to be what you get comfortable using, and then sometimes just being creative. So for medication costs, we typically use two sources. One is Micromedex Redbook, and then we also use the VA drug pricing database, which is publicly available data. The VA pricing is going to be lower than Redbook, but Redbook is good too. And then I'll show you in a second. There's a lot of different numbers associated with medication costs, and the one that we typically use is WAC, or wholesale acquisition costs. Now, I showed this slide not because I really want to walk you through it, but just to show how complicated medication pricing is. So we have a lot of people involved in medication pricing. We have a manufacturer who makes the medication. They send it to a wholesaler. Wholesalers are who sell it to pharmacies. There's pharmacy benefit managers. If you don't know what a pharmacy benefit manager is, good for you, because they're kind of a pain. The patient actually has to buy it, and then there's the health plan and the insurers. And so PBMs, these pharmacy benefit managers, are more or less a middleman between all these people. Anyway, my point here is that there's a lot going on in setting drug pricing. It's not just a simple fair market value issue and question. And this is almost an entire discipline all by itself of understanding drug pricing. So we often overly simplify drug pricing, and that's okay. I also just showed this to show all the different names associated with different drug prices. It's so easy, again, to get lost in what do these mean? What dollar value should I use? And for simplicity's sake, I just recommend that you use the WAC, the wholesale acquisition cost. For inpatient pricing or costs, there's a couple places that I get it from. So the Healthcare Cost and Utilization Project, HCUP, this is an AHRQ funded project. They provide data from the National Inpatient Sample, and you can use ICD-9 or ICD-10 and CBT type codes to pull and look at data. This is publicly available as well, but it does cost money, but it's relatively cheap. And then you can also sometimes get it from the health system. So I also put this link in, the cost to charge ratio. So when you get data from your health system, typically what it is going to be not going to be cost, but it's going to be charges. And these two numbers are actually not identical. So charges are what we charge the insurance, and costs are what they actually pay. And they typically pay a negotiated or a discounted rate. So let's say we bill $1,000 to the insurance for a hospitalization, and then they pay $500 based on that discounted rate or negotiated rate for that event. That we have a 50% cost to charge ratio. So you can use and these are hospital specific ratios, or I believe they're hospital specific. Maybe I need to double check that, but I know that they vary. It's not a universal rate, and you just want to be careful that you're not using charges. We're trying to get to costs, and sometimes we do have to use charges, and that's okay. And if we use charges, we need to be very explicit that, hey, these are charges, these are not costs. For chronic costs, or I often use MEPS, or the medical expenditure panel survey. Again, here's a link. You can look at the data. So a lot of these data sources are all by themselves rather complex, and so it's not something that we have time to go through in detail in this course. We can use the Bureau of Labor Statistics for things like wages. I often get labs and visit associated costs from the CMS Physician Fee Schedule, which is a publicly available database. And then don't forget that you can always find someone else's published work. So people do research on costs just by themselves. So not doing CEA, not doing cost effectiveness analysis, but just evaluating costs. And so you can go grab those published estimates, cite them, and that's another great way to get costs. So now let's just talk about, those three things are kind of the big thing I want you to take away from this lecture is identifying the resources that you want to use, quantifying how often or how much get consumed, and then assigning a price to the resource. There are a handful of other costs that we're not going to really go through in detail, but I do want to just kind of point out a couple of things. So we have like productivity costs. Again, so if you go back to that impact, impact inventory, these kind of fall into that societal cost that we often don't look at. But when a patient is not being productive because they are ill, that is a cost to society. There's time costs, so the patient has to spend time traveling to and from the doctor's office. There's caregiver time. There's other costs outside of the healthcare sector that can all be influenced by what we do inside the healthcare sector. I often don't do this or don't include these costs, again, because I usually take on a healthcare sector perspective. But I just want to remind us that they exist. So that way, if it's important for you and for your question, that you remember to go and examine them. There's two important key ideas called discounting and inflation. And these are different. I think we'll start with inflation because I think most people are familiar with this word and this general idea that prices increase over time. And essentially what that means is if the dollar amount that we pay for a good or service today is probably not what that good or service is going to cost in the future. And one way that we can adjust our price. So what we want to do is we're trying to get our costs down into a common denominator year. Usually we inflate our costs to whatever our current year is. So the year 2024 is probably the most recent data that we have. But in in a little bit here, we'd be inflating things to 2025. The consumer price index is commonly used to inflate costs. This is from the Bureau of Labor Statistics, and they actually there's an overall consumer price index, but then they can break down the consumer price or the individual sectors involved. So you can actually use a healthcare sector version of the consumer price index to get all of your costs into equivalent years. But inflation is a little bit different than discounting. So discounting refers to the idea that the value of money is different today versus in the future. So we tend to prioritize the future over, or excuse me, we prioritize the present over the future. We want money today. So if we're going to incur a cost, we want to incur it in the future. And I think the easiest way to think about this is if anyone has ever taken out a loan, you've shown that you value money today more than you do in the future. So let's say you borrow $10,000 to go to school, to get an education. But you know that you're going to pay back that $10,000 with interest. So, maybe you end up paying back $15,000, but you valued that money today so you could do something with it more than you valued paying it back into the future. And the same thing can be true for investing in other things. But that's the idea of discounting. So we both inflate our money to make sure that we're in the same year, and then we discount it for anything that happens more than 1 year into the future. So 1 year tends to be the kind of magic mark where if the thing or the good or the service is being consumed within the year, we don't do any discounting. But once we go beyond a year, we often discount at about 3% or 3% per year. Again, I'm going to kind of skip over this a little bit. I don't like getting costs from other countries. And you can, in theory, convert costs into a common currency using exchange rates or purchasing power parities. Exchange rates are, exactly what all of us are familiar with. Purchasing power parities are a method to try to actually compare buying power in different countries. So they're going to just be less prone to random fluctuation based on a lot of things. It's how much does bread cost in the U.S. versus how much does it cost in another country? But healthcare costs are so different from country to country that it really is incorrect, in my opinion, to try to take costs from a different country, convert them into an American currency, and use them here. And that's it. That's all I have for this lecture. So I hope this was helpful. We'll go over any questions you have in class, and we'll use some examples of how we actually analyze costs and build cost data sets in class.